This is the second set of voice over PowerPoint. We're going to talk about anticoagulant drugs and the coagulation cascade. You've seen this slide before, it's about the outline. Well, before we talk about the anticoagulants, whether they are parenteral or oral, we really have to talk about the coagulation cascade. I know there's some repetition, but it's okay. We're going to point out what is relevant to us here and what will allow us to better understand the coagulation test and how the anticoagulants work. I don't know if you've seen this slide before. I borrowed it from Dr. Shab. And I made some edits to it that are relevant to us. Well, this is the coagulation cascade. As you can see, we have the extrinsic pathway, the intrinsic pathway, and the common pathway in green. The first thing I want to point out is that really this differentiation between the extrinsic and the intrinsic pathway is not perfect, as there is definitely some overlap. And you can see here this overlap with factor 9. For instance, factor 9 in the intrinsic pathway is activated into factor 9A via factor 11A intrinsically, and then it binds to factor 8A, whereas in the extrinsic pathway, the tissue factor 7A complex activates also factor 9 into 9A. So you definitely have overlap. Another overlap is with thrombin, factor 2A. For instance, thrombin is coming from prothrombin via the common pathway, but then it goes back into the intrinsic pathway, whereby it activated factor 11 to 11A and 8 to 8A. And remember what we said in the first voice over PowerPoint, actually thrombin is also involved in platelet aggregation, right? So let's go back to what happens in the beginning. Extrinsic pathway is relatively well understood. We start with tissue injury, and that leads to exposure of tissue factor or thromboplastin. And tissue factor binds with factor 7A. Factor 7A auto-activates, and we discussed that this activates factor 9 and factor 10. Now, concerning the intrinsic pathway, also called the contact system, we really don't understand it as much as we understand the extrinsic pathway. We understand it in vitro, but anyway, we start with factor 12, and with the help of high molecular weight kininogen, we get it activated into factor 12A in addition to prekallikrein becoming kallikrein, and this leads to activation of factor 11 to 11A. And then we already agreed that with factor 9, factor 11A would attach to factor 8A. And ultimately, what this does is activation of factor 10 into 10A. So there are two ways of activation of factor 10, one from the intrinsic pathway and one from the extrinsic pathway. Ultimately, with factor 10A, we're going to bind to factor 5A that is activated via thrombin. And this will lead to actually activation of prothrombin into thrombin. This leads to activation of fibrinogen into fibrin. And in order to have cross-linking, you need factor 8A so that we have a stable hemostatic plug. Now, the few things that I want to point out are the following. What we have in yellow is the phospholipid surface of the platelets. So remember that all of this is really happening around the platelet, and we need the phospholipid surface of the platelet for some of the pathways to occur. Also, we need calcium. Calcium is very important into several of the reactions. 3, there are some factors that are cofactors and some that are enzymes. So the cofactors are highlighted in a blue square, whereas the enzymes are actually not highlighted. So what is in blue is a cofactor, and what is highlighted as a red square are when is cofactor attaches to something else, and the others are enzymes, as we will see in the next slide. So here's a summary of the coagulation factors that we discussed. Of course, I don't want you to remember the names, but I put them here just for your curiosity. So we have up to 13 coagulation factors. Some of them are cofactors, others are enzymes, and actually most of them are serine proteases except for factor 13, that is a transglutaminase. And I highlighted in colors to differentiate what is intrinsic, what is extrinsic pathway, and what is the common pathway. And we already agreed that there is an overlap. What this slide is showing us is how the factors are activated, and the activation is done via prekallikrein and serine proteases. And in the slide here we have an example of the activation of factor 5 that is made of a light chain and a heavy chain, and how factor 9a activates it. It actually cuts a place in the heavy chain, and that leads to exposure of serine, and hence we have an active factor 10a that would then go activate other factors. This is again a very nice movie done by our book, and I highly recommend that you access the site and you watch it. If you want, you can start with the first 2 minutes where they explain the process of coagulation, and then the rest of the movie you can watch it after we discuss a little bit the mechanism of action of the anticoagulants. It's really well done. I highly recommend that you watch it. And this is another slide showing us the coagulation cascade again in the vicinity of the injured vessel and at the platelets. Of course, not everything is mentioned here. What is mentioned are the factors that are important in vivo, and one can differentiate the extrinsic from the intrinsic from the common pathway. Now is the time to talk about the coagulation test. Maybe you already discussed in other talks about if you want to test for bleeding, you can do a bleeding test, you can do a platelet count to check the platelet number. When for coagulation, when we give anticoagulants, we want to do some testing and see if the anticoagulants are working well or not. So how do we do that? Let us explain the test. An old test that we don't do anymore is very simply the whole blood clotting time. So basically, you bring blood, you withdraw blood into a tube, and you wait for some time. Ultimately, it's going to coagulate. It will take about 4 to 8 minutes. Usually now when we take blood, we take them in a citrated tube. Why do we do that? As citrated tube is a chelator, so that it chelates calcium. Remember, we said that calcium is very important for the coagulation cascade. So when we withdraw blood from the patient, we don't want it to coagulate right away. We want it to go to the lab and then test it in the lab, right? So we put it in a citrated tube, and if we want to check the clotting time, when we are ready, we add calcium, we recalcify, and it's going to clot within 2 to 4 minutes. So this is an old test that we used to do, but now we have another test, and that is the activated partial thromboplastin time, or APTT, that measures the intrinsic pathway. Here I want a test that measures the intrinsic pathway and a test that measures the extrinsic pathway. Why is that? Because there are some anticoagulants that mainly affect the intrinsic pathways, other that mainly affect the extrinsic pathways. So, and I want to check how well those drugs are working, so I do those tests. Now to go back to APTT, it's really a whole blood clotting time, just like the one we just explained, but we make it faster. We shorten the time to get coagulation. And how do we do that? In addition to recalcification, so in addition to adding calcium, we also add kaolin. And kaolin is a particulate aluminum silicate that activates factor 12. And hence now we understand why this is intrinsic pathway. In addition to that, we have to add negatively charged phospholipids. Remember, we said that phospholipids on the platelet membrane are very important. So in addition to calcium and phospholipids, what is peculiar here to APTT being for the intrinsic pathway is that we add kaolin. Another test is the prothrombin time, PT, and this test is to measure the extrinsic pathway. So when you think of the extrinsic pathway, you would think of the tissue factor, right? So what they used to do in the past, they used to add thromboplastin, and that is a saline extract of the brain containing tissue factors and phospholipids, of course. And what they used to do, they used to report something called the PT ratio or the PR, which is the PT of the patient, how much time does the blood need to coagulate versus a control. A control is done based on several patients. But now we don't do this ratio anymore. Why? Because we don't use the brain extract. Now we use a recombinant tissue factors that is synthetic in addition to phospholipid, and this is called recombiplastin. And because of that being synthetic, the company gives us something called the International Standard Index, because every time they do this test, the values may change a little bit. And in order for the different labs to standardize, so for example, if a lab at AUBMC gives me a value, I would understand it in the same way as if this same test is done in another lab. So that for standardization, every kit comes with an international standard index. And what we do, we calculate the international normalized ratio or INR, which is the PT ratio, the PR, exponential ISI. And this normally in normal people, not normal people, in people who do not have liver disease, for example, or people who are not taking anticoagulants, the INR should be between 0.8 and 1.2. And you would expect if a patient is taking an anticoagulant that affects the extrinsic pathway, the INR is going to be higher, right? Meaning that it will take more time for the blood to coagulate. We have seen this table before together, and the only thing I've added is that for the intrinsic pathway, we measure APTT, and for the extrinsic pathway, we measure PT-INR. Now moving on, we want to remind ourselves how is the coagulation process controlled and terminated. For instance, we don't want the coagulation process to continue forever, or we don't want us to have thrombus without any reason. So one, any procoagulants or activated factors can be removed through the reticuloendothelial system, especially in the liver. We also have natural antithrombotic pathways. I failed to point it out on the slide that I borrowed from Dr. Shab, but we have the tissue factor pathway inhibitor that will inhibit excessive coagulation. Please have a look at it. We also have the protein C pathway, and I'm sure you're going to take a session about protein C and S and how if somebody has a genetic polymorphism in the genes leading to those proteins, and those people may be prone to more coagulation, they may present with deep vein thrombosis, etc. And finally, the last factor is antithrombin 3. This is a circulating plasma protease inhibitor. So this is very important. It forms complexes, especially with factors 2A, 10A, 9A, 12A, and 11A, but mainly really 2A and 10A. So antithrombin 3 inhibits those factors, especially 2A and 10A. And this again is the same table that we've seen before, highlighting where antithrombin 3 works. And you can see that in addition to the common pathway, we have inhibition of the intrinsic pathway. We're done with this first part. Now is the time to finally talk about the anticoagulants. We will first start with the parenteral anticoagulants that are actually antithrombin 3 activators. So we are going to activate antithrombin 3, and then we will talk about others, oral anticoagulant drugs that work differently. The antithrombin 3 activators, we have the IDTI for heparins, unfractionated heparin, and low molecular weight heparin. What is IDTI? It is indirect thrombin inhibitors. Why is it indirect? Because we are inhibiting thrombin, but indirectly. How is this happening? This is happening by activation of antithrombin 3. This is in contrast to DTIs such as bivalirudin, or down there dabigatran, that is an oral anticoagulant, DTIs are direct thrombin inhibitors because they simply inhibit thrombin directly rather than through activation of antithrombin 3. So what are antithrombin 3 activators? We have, again, we just discussed that those are indirect thrombin and 10A inhibitors. Remember, we said that antithrombin 3 forms complexes with several factors, but what is most relevant to us in vivo is thrombin and 10A. So by activating antithrombin 3, we're going to inhibit thrombin and 10A. And the three drugs that we're going to discuss here are unfractionated heparin, low molecular weight heparin, and pentasaccharide. Before we move to those drugs that activate antithrombin 3, I'd like to show this old experiment done really a long time ago, showing how the addition of heparin, for example, in this case as an antithrombin 3 activator, works beautifully. So what we have on the y-axis is thrombin activity. How is thrombin activity measured? Well, in this case, it's very simple. They see how much of the fibrinogen becomes fibrin. So if we have thrombin alone, we have, of course, normal 100% thrombin activity. Now, if we add antithrombin to thrombin, then this activity decreases, as you can see in the line in the middle. Whereas when you add heparin to it, in this case, we will have a beautiful decline in that line. You see it is highlighted in green. So showing that those drugs augment antithrombin 3 inhibition. The first drug that we're going to discuss is unfractionated heparin, or we tend to call it heparin. So what is unfractionated heparin? It's a polymer, really, many sulfated D-glucosamine with D-glucuronic acid. And we have varying molecular weights, so several sizes. It could be 500 up to thousands. It really depends. So it's a mix of glucosaminoglycans. When was this discovered? Interestingly, it was discovered by a second-year medical student. Well, in 1916, that medical student was working in the lab with blood and testing some coagulation, etc. And then he worked late at night, and he did not have the time to wash the tubes when he was done. So he left the tubes on the bench, and then he went home. When he came back in the morning, he was planning to wash those tubes, and you would expect that the blood is coagulated, right? Well, it turned out that in some of the tubes, the blood was not coagulated, so blood spoiled his lab coat. Interestingly, is that he did not just leave it like this. He thought about it, he observed the phenomenon, discussed with his mentor, and it turned out that the reason why this blood remained anticoagulated is that because they had unfractionated heparin in them. Very interesting, I think. When you go to the hospital and you start prescribing unfractionated heparin, people talk in unit. And I wrote it down here for you. 1 unit of heparin is the amount that would prevent 1 cc of citrated cheap plasma from clotting within 1 hour, of course, after adding calcium. So again, unfractionated heparin, as you can see in the green square, we have several lines of different sizes. So it's a heterogeneous mixture of different sizes of glycosaminoglycans, and the molecular weight varies. Those are coming from natural sources, from either the porcine intestinal mucosa or the bovine lung that are rich in mast cells. What really matters in this glycosaminoglycan mixture is that pentasaccharide. So the antithrombin binding structure is this pentasaccharide that you have here. And what is highlighted in red are the sulfate groups that are important to bind to antithrombin. In this figure, we see how unfractionated heparin works. So the most important part is this pentasaccharide sequence. And once unfractionated heparin binds to antithrombin, you can see that you have a conformational change in the reactive center loop of antithrombin. It changes, and hence now it better binds and inhibits factor 10A and thrombin. It's very important to note that the length of the unfractionated heparin is important for thrombin inhibition. It's not the case for factor Xa. So for thrombin to be inhibited, the binding of unfractionated heparin to antithrombin is not enough. It also needs to bind to thrombin so that the effect is much more. This is not the case for factor Xa. For factor Xa, the mere fact of pentasaccharide attaching binding to antithrombin is enough. Now, unfractionated heparin, remember we said it's a mixture of glycosaminoglycans of different molecular weights, and the average is about 15,000, so it should be enough to inhibit both factor Xa and thrombin. Some pharmacokinetic parameters of concerning unfractionated heparin. It's okay to give it in pregnancy. Why? Those are large molecules, glycosaminoglycans, so they would not cross the placenta and hence they would not affect the fetus. Of course, they might affect the pregnant woman. Again, we discussed that there is a higher risk of bleeding with all of those drugs. You will see some other side effects with heparin. For example, we may have thrombocytopenia, we may have osteoporosis if chronic use, but it does not affect the fetus, so it's safe in pregnancy concerning the fetus. It is eliminated by the reticuloendothelial system, which is important because we will see that other indirect thrombin inhibitors and also fondaparinux, that is a 10A inhibitor, are affected in kidney disease. This is not the case for unfractionated heparin. Now, because of its large size, and it is polar, by the way, it is negatively charged, we only give it parenteral. It cannot be given orally. We prefer to give it IV. If we give it subcutaneously, the absorption is very erratic. We may give it subcutaneously, as we will see in later slides, for prophylaxis, but the usual preferred route of administration is IV. We do not give it IM because there's a risk of hematoma. The effect is immediate but short, so we have to give it continuously. And the big problem of it is that we have non-specific bindings. So not just 2A and 10A and the other factors. It may bind to other proteins, other tissues. So we have a very highly variable effect. So we have to monitor it with APTT. We already agreed that all antithrombin activators, we monitor their effect with APTT, and for unfractionated heparin, we have to monitor it because the effect is highly variable. Adverse effects, we have heparin-induced thrombocytopenia, or HIT. We're going to talk about it later. We may have allergic reactions. Remember, heparin is coming from natural sources. We may have osteoporosis with long-term use, and of course, bleeding. We discussed that this is an extension of the therapeutic effect, so one has to be very careful in dosing. We have to monitor. We want to make sure that we don't have over anticoagulation, and we want to screen for risk factors and contraindication. And let's see what those are. So we have some warnings and some contraindications. So before we start heparin, we want to see, is our patient a hemophiliac? Does our patient have a dissecting aneurysm? And this is kind of tricky because the patient would come to the emergency room with chest pain. Most probably it's an MI, but you want to make sure it's not a dissecting aneurysm where you would have bleeding, for example, in the aorta between the intima and the media. And if you give an anticoagulant, the bleeding would be even more, and you may have rupture. You may want to be careful if the patient has a peptic ulcer disease, severe hypertension, the patient may bleed, threatened abortion, and of course antiplatelet drugs. It doesn't mean that we cannot give those drugs with antiplatelets. It's just a warning. Be careful for excessive risk of bleeding. Now we do have contraindications if we have thrombocytopenia, very low platelet count. If the patient has uncontrollable bleeding, the patient is coming with bleeding. Remember that first clicker question we had in the first voice over PowerPoint. You don't want to give an anticoagulant when the patient who has bleeding. You do not want to give it to patients who have brain surgery, eye surgery, or spinal cord surgery, because if you have bleeding in those very close spaces, then it's very problematic. If you have bleeding in the eye, that may push on the optic nerve and the patient may become blind. If you bleed in the spinal cord, one may become paraplegic, etc. And the same thinking concerning lumbar puncture and regional anesthesia. So one has to be really careful with that. Now, if a patient bleeds on anticoagulant and fractionated heparin in this case, well, the good news is that we can have an antidote. So protamine sulfate is an antidote that you can give in the hospital. It's a mixture of polypeptides isolated from salmon sperms. It's highly positively charged, so it tightly binds to heparin and neutralizes it. But one has to be careful because in addition to heparin, it may also interact with platelets, fibrinogen, and other proteins, so it may have an anticoagulant effect of its own. So one has to be careful. There is a way we calculate the dose of protamine that is needed to be given in relation to the heparin dose. And protamine sulfate works very nicely with unfractionated heparin. It works less with low molecular weight heparin that we're going to discuss in a few minutes. And it does not work with fondaparinux, fondaparinux being the pentasaccharide. So it does not neutralize fondaparinux if a patient is having bleeding with fondaparinux. Concerning heparin-induced thrombocytopenia, HIT, we have type 1 and type 2. Type 1 is very common, and what happens here is a direct interaction of heparin with the platelet membrane, resulting in enhanced platelet aggregation. So the platelets aggregate together, and if you measure the amount of platelets, they will be low. This is 10% of the patient. It happens within the few days of treatment, and it may resolve. Usually, it's not associated with bleeding and not associated with increased risk of thrombosis. The platelets does not usually go below 100,000. But the point here is that you really want to monitor the platelet counts when you are giving a patient unfractionated heparin. The more scary HIT is HIT type 2, and type 2 is immune mediated. Here also we have thrombocytopenia and increase in thrombotic events. Again, we have the platelets aggregating and hence decrease in count. It is less common than HIT type 1. It's associated more with the bovine lung than with the porcine one. And it occurs less frequently in patients receiving low molecular weight heparin that we're going to talk about later. It does not occur with pentasaccharide. We will see that the fondaparinux is synthetic. So the highest risk is with unfractionated heparin, followed by low molecular weight heparin, and none with fondaparinux. The platelet number will go below 100,000, and this may be serious and the patient may die. If this happens, you want to stop the treatment and you may need to give treatment such as prednisone. What is the mechanism? I wrote it down here for you. It's not for your memory, but again, remember that this is an immune process. Before we move to low molecular weight heparin, I put this slide again highlighting some problems in the pharmacokinetics of unfractionated heparin that we have discussed so far. We said one, that we have to give it IV, and we cannot give it subcutaneously because of erratic absorption. And now imagine that you have a pregnant lady who has a deep vein thrombosis and you want to give her heparin for 9 months. I don't think it's a good idea to give her an IV for 9 months. You want something that is given in a different way, such as subcutaneously, ideally orally, but so far the oral anticoagulants cannot be given in pregnancy. Another problem is that it is short acting. We have to give it continuously, and that would not be fun again in a pregnant woman. And this highly variable effect, so we really want to monitor closely so that the patient doesn't bleed. So what do we have now? Now we have low molecular weight heparin. What is low molecular weight heparin? It's basically a depolymerized unfractionated heparin. It's again coming from the bovine or the porcine source, and the companies cut it into smaller heparin. So instead of starting with the larger molecules, now we have smaller size molecules. Again, also it is a heterogeneous mixture, but they are definitely smaller. Examples are enoxaparin and tinzaparin, among others. So we said depolymerization of unfractionated heparin. Elimination here is preferentially via the kidneys, and we talked about that before with unfractionated heparin. It's mainly the reticuloendothelial system and not the kidneys. So here you think of your patient, whether this patient has kidney disease or not. It is more bioavailable. Here, what I mean by bioavailable, I mean via the subcutaneous route. We don't give it orally, okay? Because more bioavailable and more precise binding, we really don't need monitoring. We're comfortable that whatever dose we're giving is going to give us the effect that we expect. It has the same toxic effects like unfractionated heparin, but much less. For example, less bleeding and less risk of HET type 2. In case we have bleeding, we can neutralize it with protamine sulfate, although the effect is less consistent than that with unfractionated heparin. And what does it inhibit? It inhibits both factor Xa and thrombin. But remember, we said that for thrombin, you need a larger molecule. So maybe with low molecular weight heparin, because they are smaller, the effect will not be as good with thrombin. It will be as good with factor Xa. And as a matter of fact, in this figure, we can see that the mean molecular weight of low molecular weight heparin is 4,500 to 5,000. So the most of the effect will actually be again against factor Xa rather than thrombin. Third, indirect inhibitors, in this case the antithrombin activator is fondaparinux. So what is fondaparinux? It is synthetic. It is the pentasaccharide, just the pentasaccharide. That's it, no more. And you would expect it to inhibit factor Xa, not thrombin, right? For the same reasoning that we discussed before. It has a long half-life, so it's nice to give it once daily. It's given subcutaneously. The problem with it is that it accumulates in renal failure, so we have to be very careful in patients who have very low creatinine. The nice thing about it is that there is no HET type 2 in this case. And this is how it works. So you would expect what's happening, and it activates antithrombin, and which leads to inhibition of factor Xa. Now it's probably the time to go back to the same movie and watch the second part to see how those anticoagulants that we have been discussing work. And this table compares unfractionated heparin with low molecular weight heparin and fondaparinux, and I believe it is straightforward for now. So what we have done so far are parenteral anticoagulants, and specifically we talked about the antithrombin activators, and hence being indirect thrombin inhibitors. Who are the indirect thrombin inhibitors? For sure, unfractionated heparin and low molecular weight heparin, not pentasaccharide, because pentasaccharide by activating antithrombin it inhibits only anti-10A, right? So now it's the time to move to direct thrombin inhibitors. What is interesting about those is that they don't need, again, antithrombin, right? Unlike heparins, also, another important thing about them is that they inhibit both clot-bound and circulating thrombin. Be careful, it doesn't mean that they dissolve the clot. Remember, only the fibrinolytic drugs dissolve the clot. However, they may be good to prevent it from further growing. Also, they do not bind to platelet factor 4, and hence we do not produce thrombocytopenia. They have a more consistent bioavailability. In the past, we did not have an antidote. That was problematic. We already know now that for unfractionated heparin and low molecular weight heparin, if we have bleeding, we have an antidote that is protamine sulfate. With the direct thrombin inhibitors, we did not have an antidote, but now we do have one, idracizumab, which is a monoclonal antibody, although I'm not sure if it is available in at AUB-MC. Dabigatran, by the way, is a direct thrombin inhibitor. So here this figure is showing us why heparin does not inhibit the fibrin-bound thrombin, whereas it inhibits the soluble thrombin, simply because heparin is too big and would not really be able to reach the site of action in the fibrin-bound thrombin. Well, this is not the case for the direct thrombin inhibitors, and we have two types of direct thrombin inhibitors, the univalent ones and the bivalent ones. So we have dabigatran, we already mentioned it, and we also have bivalirudin. Bivalirudin is given IV, so it is a parenteral anticoagulant. And now we're moving to the oral anticoagulant, dabigatran or Pradaxa. Some differences in addition to the formulation being oral or IV. Elimination, for instance, for dabigatran is only kidney. For bivalirudin, it's both kidney and liver, and there are different reasons to use that. You would understand that bivalirudin is given for PCI, it's given in the hospital as IV, whereas the oral anticoagulant would be given at home, for example, for patients who need VTE prophylaxis, venous thromboembolism prophylaxis, if they have non-valvular atrial fibrillation. Note the non-valvular atrial fibrillation because we don't have data concerning valvular atrial fibrillation. The drug, the oral anticoagulant drug that is approved for valvular atrial fibrillation is warfarin, that we will see towards the end. We're done with the direct thrombin inhibitors, the DTIs. Now let's move to the direct factor Xa inhibitors. Remember, who are the indirect factor Xa inhibitors? Well, those are unfractionated heparin, low molecular weight heparin, and fondaparinux, right? So now what are the direct factor Xa inhibitors? Those again, they bind to Xa directly rather than through antithrombin. Also, the same, they inhibit clot-bound and circulating factor Xa. The typical drug is rivaroxaban. It is given orally, both kidney and liver elimination given once. Also, for VTE prophylaxis with non-valvular AFib, less bleeding than warfarin. So warfarin is a drug, the very old drug, oral anticoagulant that we used to give. The problem with it is a lot of bleeding. It turns out that rivaroxaban probably less bleeding. However, no antidote. But recently we have one, a monoclonal antibody, although again, I'm not sure if we have it in Lebanon. So what are the DTIs and the direct anti-10A? We call them the DOACs, or more specifically, direct oral anticoagulants. This is a common nomenclature. We have to be careful. Those should be avoided in heart valves, pregnancy, we don't have studies, renal impairment, patients with compliance problems, because we will see in the third voiceover PowerPoint when we talk about warfarin, we can monitor with INR actually, PT INR that we discussed before. So I don't only rely on the patient taking the drug or not, I actually measure the blood test and make sure that the patient is adequately anticoagulated. Whereas with those DOACs, I am really not able to monitor whether the patient is really taking the drug and whether the patient is really being anticoagulated, which could be problematic. There is no antidote that is readily available. We will learn with warfarin that the antidote is simply vitamin K. In this case, if the patient is bleeding on a DOAC, there is nothing I can do except fresh frozen plasma. And cost, definitely, they're more expensive than warfarin.